Good afternoon, everyone. I'm honored to open the session number 5, and I'm also honored to be part of the Osstem AIC, one of the most important scientific community in the world. I'm Marco Talarico. I live and work in Rome, Italy, and I'm an active member of several academies worldwide, including Osstem AIC, where I have the privilege to be the president of the Italian section. Today, my topic is new challenges in guided surgery. Anyone who knows me knows that I love guided surgery and digital dentistry. I wrote a book with my best friend, Professor Silvio Meloni, reporting 15 years of our experience. From this wonderful experience, I learned that guided is digital prosthetic plan. Again, guided is the key of the success, and digital is more than this. However, digital alone is not sufficient. Tradition must to inspire the modern technologies. Today, I will tell you of a story of a special patient for me. Her name is Laura. She was 62 years old in 2013. She now is 70 years old. I met her for a consultant because Laura reported that she received a new prosthetic rehabilitation less than 2 years before my visit, but she has never been satisfied, and her major concept was difficult to eat, speech, pain, and discomfort. This was the clinical situation 8 years ago with and without the removable prosthesis. Occlusal view on the lower jaw with and without the removable prosthesis, and the same in the maxilla. She referred to me that she could not longer cope with her poorly fitting denture. The same for the pain and discomfort, but also the periapical radiograph confirmed a periodontally compromised situation in both upper and lower jaws. The diagnosis was very easy in this case, failing dentition in upper and lower jaws. In 2013, my treatment plan was extraction of all the teeth, immediate complete removable denture, prosthetically driven implant placement, and finally implant-supported fixed rehabilitations. However, she couldn't afford the fee for a new treatment, so I haven't seen her for 6 years. 6 years later, in 2019, she came back in my clinic in this clinical situation. She was not wearing her prosthesis for several years. In the upper jaw, the dental condition was almost the same, while now in the mandibular she just had a solitary tooth, solitary canine. The radiograph still confirmed the failing dentition in the upper jaw. So the new question is, which treatment plan? The same of 2013? Yes, the treatment plan was about the same, with 2 exceptions. Firstly, I plan an implant prosthesis named diagnostic denture because I need to rehabilitate the function of the patients. And then for economical reasons, I enrolled the patient in several training events and live surgery so I can give to her free of charge a mandibular overdenture and maxillary all-on-4. Always prosthetically driven approach. My treatment plan started with the new complete removable prosthesis. The first step is to take 2 extended preliminary impressions in alginate in both the upper and the lower jaw, using dedicated impression trays for a dentulous patient in the mandible, bordered with soft wax. Here you can see a short video of the procedures. First of all, I need to measure the size of the impression tray. Even if it's standard, I want a maximum accuracy as possible. In the lower jaw, I use a dedicated impression tray for dentulous patients, and I use alginate first in the patient mouth and then in the impression tray in order to record as much as possible the detail of the anatomy of the patients. Now I have to wait the fitting time. Usually I wait a little bit more than the suggested time. But again, it's most important that impressions are as much extended as possible. Same in the upper jaw, but in this case with a standard impression tray because the patient has the teeth in the anterior maxilla, but with the same technique, a fluid, liquid flow alginate on the teeth and then alginate on the impression tray. And the same, we wait for the setting time. After that, I have two extended impressions, so now it's possible to pour the study model. Again, the study model can be poured with a boxing technique for the same reasons, because I need extended study model pouring using gypsum type 3. This is the model for the lower jaw and the same for the maxilla. The primary models were used to fabricate the customized impression tray according to a model tracing. This allowed to define the correct extension of the customized trays based on the anatomy of the patient. This is a crucial and most important step to obtain a good definitive impressions. The same in the upper jaw tracing model. Finally, our dental technician can send to us the upper customized impression tray with a preliminary occlusal bite registration made in red wax due to the presence of oplet teeth in the maxilla. While in the lower jaw, the dental technician sent to us the customized impression tray and a modeled occlusal bite registration also with a resin base. Before definitive impressions were taken, the customized trays were tried and fixed in the patient mouth if needed, in order to avoid pre-contact but to add material if needed. Again, you can see a short video of a simple but efficacious impression technique to avoid compromised teeth removal during the impression. According to this technique, I use a polyether material in a flow-light consistency in the buccal part of the compromised teeth. There are a lot of undercuts, but it's not important because for the buccal part, I just use the polyether materials. So, after 3 minutes of the initial setting, I started with a polyvinyl siloxane material, different materials, in the palatal portion, and the same material but in medium consistency will be used in the customized impression tray that will be set vertically. So at the end of the procedure, I have the polyvinyl siloxane materials that will be removed in the same way it is put, so vertically like the video, and the polyether material that is removed horizontally. The polyether material is a very rigid material, so it is very easy to remove from the undercuts of the teeth, but also very easy to reassemble on the impression. We need to wait 1 to 2 hours for the elastic memory of the silicone materials, but then we can obtain a good study models, avoiding any risk for the residual teeth. So at the end, I have the definitive impression, occlusal vertical dimension, and centric relaxation. So in the same clinical section, I also recorded the maxillary position using a conventional face bow oriented at the campus plane. I also record the phonetic sounds because I need to check as is possible the phonetics. I want to highlight that the patient have the residual teeth, but it's possible with the F sound and the S sound to determine the length and the inclination of the upper and lower teeth respectively, and to communicate this information to the dental technician. So it is able to finalize the immediate diagnostic removable denture. The day of the surgery, I need to remove the teeth, and I want to highlight that it's very important to cut any old bridge or multi-rooted teeth, not in this case, in order to have atraumatically extraction is very important. Moreover, in this case, I have just a very small guide to reduce a little bit the bone according to the immediate denture, just to remove some bone peak that could create pain and discomfort in the initial healing phase. The day of the surgery, Laura rediscovered her smile and function. Here you can see the occlusal view after surgery. As I told you before, the patient was edentulous for several years, so a lingualized occlusion was mandatory during healing and during the rehabilitation. This is the situation, the sutural removal. Base fit and occlusal control were performed every 2 weeks up to 4 months in order to find the correct centric relaxation. Occlusal vertical dimension was never changed because the patient wasn't comfortable. Using this approach, the mandible was free to move in the most comfortable position. 4 months later, after the functional rehabilitation, the prostheses were rebased with the impression materials in order to create the definitive model for the definitive restoration in a technique that is named like cross-mounting technique, in order to maintain the occlusal vertical dimension and the founded centric relaxation. 5 months after the first surgery, I delivered the definitive prosthesis, and I used this prosthesis to plan my implants. The first implants was 2 lower implants to deliver an overdenture. According to the plan, you can see here, I virtually plan 2 Osstem TS3, 3.5 millimeter of diameter, 11.5 millimeter of length, to retain an overdenture. Here you can see the one guide kit. I love dynamic guided surgery, so I put the template, I remove, I open a flap if needed, I check the position, I put the template again. I really enjoy also the one guide kit without metallic sleeve, and I will show you some very interesting results. Again, I remove the template to check, to perform a very slight bone reduction, but also to check the implant position. Finally, 2 implants were placed as parallel as possible according to the virtual plan, left implant and the right implants. In the same surgical section during live training, we also delivered the attachment and performed immediate loading on the delivered prosthesis. This is the situation after a few days of healing and a few months later, where you can see a good amount of keratinized tissues. On June 27, 2020, maybe most of you will remember that I performed the live surgery in the maxilla during the Osstem World Meeting, maxillary all-on-4 with crestal bone reduction and immediate loading. But before the surgery, the patient wore the complete removable denture in the maxilla and the 2 implant retained overdenture in the mandible. This is the situation before the surgery, and this is the plan. For this case, I plan a classical all-on-4 with 2 anterior straight implants and 2 posterior tilted implants. Due to an horizontal bone atrophy in the anterior maxilla, I also plan a 2 to 3 millimeter of vertical bone reduction. This allows me to have more space for the definitive prosthesis, but also to place the implants in the bone, avoiding any kind of problems due to the bone atrophy. Also, according to the plan, I calculate in advance the multi-abutment, 2 straight multi-abutments in the upper and 2 tilted 70-degree multi-abutment in the lower. In this case, I plan 4 regular TS4 implants of 11.5 millimeter of length. All the implants have the same length and the same diameter, making the guided surgery easier. Finally, 4 anchor pins, 2 buccally and 2 on the palatal aspect. As you know, guided surgery is a fully integrated in a digital workflow, and digital technologies offer several opportunities to improve our daily practice and finally the results for our patients. In this case, in fact, I plan the implant position as I showed you before, but I also design a multi-pieces surgical templates. These allow me to plan and perform not only implant placement, but also the crystal bone reduction as planned, and also to help me in the immediate loading procedures. In fact, the same template is composed by a base, implant part, and an index. As you can see from the left to the right, the index part, the base, and the implant part. All the templates will fit very perfectly because the bone reduction was simulated before the template was designed. Look here in the tail, the base allow me to place the anchor pins and the index portion, so to stabilize the surgical template in the patient mouth, to design the flap, to perform the bone reduction and the immediate loading procedures, while the implant part is set on the base portion to place the implants, and finally the index part is set on the base portion at the beginning to stabilize the surgical templates. Prototype models with the Osstem digital analogs, temporary restoration, metal reinforcement have been produced in advance according to the virtual plan. My dental technicians, Mr. Maurizio Gualandri, can adapt and refine the temporary restoration before implant surgery. As you can see, the base portion is designed to fix and to stabilize the temporary restoration in the correct vertical dimension of occlusion and centric relaxation, helping me to deliver the immediate loading procedures. Italian styles also allow to deliver a very nice, refined and painted temporary restoration also before the surgeries. So, moving to the surgery, maybe you already seen in the live surgery, but I want to show you an advanced speed video. Here you can see the fitting of the base portion that have a window that allow me to design and elevate a flap. After the flap was designed, after the incision was performed, I removed the base portion to elevate the flap. So, at this point, the flap is elevated and I put again the base portion using the anchor pins as a repositioning key in order to be sure that the base portion is in the correct position. Like in the video. So the base portion is designed with 4 parts in front of each implant that guided me for the amount of bone to be reduced. That is parallel in the anterior implants and a little bit tilted in the posterior according to the implant positions. After these first 4 cuts, I will remove the base portion and finalize the bone reduction, just connecting all the incision that I performed before using piezo surgery. You can see on 2 views from the frontal camera and the glasses camera. And this is the reduced bone and the wide and flat residual crest. I put again the base portion because at this point I need to prepare the implants. So I set the implant part using the initial drill, the short and the second drill at the planned length. As I told you before, all the implants are the same diameter length, so it's very easy and quick to perform the surgery. But at this point, in order to improve as much as possible the bone density, I use, without the template, the bone expander from the asset kit by Osstem. It's very nice to mix several kits in the same surgical section. So in this case, I planned immediate loading. I reduced the bone, so I have not the cortical bone in the coronal part, so I want to improve the bone density, and the expander are very nice for this purpose. Finally, I just use the final drills, but at the half length in order to under-prepare the medium and apical part of the implants, and now I can place all the implants. As I told you before, are TS4 implants, regular diameter, and 11.5 of length. All the implants reach a good stability of at least 35 Newton centimeter. And this is the final implants. Finally, I remove the implant portion and I need to screw the multi-abutment straight in the anterior implants and 70 degrees in the posterior implants. Now, moving at the prosthetic part, I just check the temporary restoration, but using the base portion I can fix in the occlusion the temporary restoration in order to be sure of the centric relaxation, but most of all of the occlusal vertical dimension. Now it's very easy to rebase and to fix the temporary restoration with the metal reinforcement inside at the temporary abutment, because I need just a very small part of resin, because the temporary restoration is planned at the virtual implant position. So just a few minutes, I want to remember that I performed all of this procedure during the live surgery of the Osstem World Meeting of 2019 in about 1 hour 10 minutes of 1 hour 15 minutes required. So during the suture, I just use a PRF to improve and speed up the soft tissue healing, and my dental technician refine directly in my clinic the temporary restoration, as you can show on the video. So it's possible to deliver in a very short time the temporary restoration metal reinforced. So maybe this was the last picture we saw after my live surgery. A few days later, the patient was very happy with her new fixed temporary restoration. Osstem implant changed the way of seeing guided surgery by introducing surgical template without metallic sleeve, but also complete surgical solution, one guide, one MS, and one cast kit, making guided surgery easy for everyone. But the question is, why surgical template without metallic sleeves? In several research, I publish interesting results using surgical template without metallic sleeves. I want to start with this randomized controller trial. I compare surgical template with or without metallic sleeve by planning implant position, scan and matching of the real and planned position of the implants, and I found statistically significant difference in vertical and in angle with better results for the surgical template without metallic sleeves. These results was confirmed also in a prospective research with more than 100 implants published in a peer-reviewed journal that concluded with very nice results, particularly compared with previous research. But the reasons why the surgical template without metallic sleeve are more accurate is because with this template we have higher and double contact between the surgical template and the guide. This is possible, look at the feature, because the metallic sleeve has standard, maybe 3.54 millimeter, while the surgical template without metallic sleeve can be customized, and sometimes it's possible to have a twice contact between the surgical template and the drill. Moreover, surgical template without metallic sleeves can be used also in narrow space, improving the accuracy in this situation. Again, it's possible to customize in case of anatomical lesion. Look at the picture. In case of anatomical lesion, metallic sleeves cannot be customized, while the template without metallic sleeves can be customized, avoiding any pre-contact. Moreover, stopless implant mount allow to have more precise accuracy, particularly in case of free and sandal situation. In case of mount with the stop, the template can move and the final accuracy can be compromised. This data was also confirmed in a systematic review that was performed in occasion of the second consensus conference of the Osstem AIC Italy that was aimed to evaluate the accuracy of the surgical template without metallic sleeves. The outcomes were angular deviation, error in depth, error at entry point, and survival rate of the implants. From 325 papers, at the end only 12 papers was evaluated with 264 patients and 614 implants. In all the three tested measures, the accuracy was higher for the surgical template without metallic sleeves, maybe for the reason explained before. Regarding the implant survival rate, no statistically significant difference were found. Coming back to Laura, 4 months after implant placement, this is the situation of the temporary restoration. The patient was very satisfied. When I told to her, at the next appointment, we will take the definitive impression, she was surprised, thinking that she was already worn the definitive prosthesis. All of us know that the accuracy of the digital impression for completely implant-supported restoration is still a challenger. So the new challenges are to improve the accuracy of the final restoration. So I want to show you my protocol that started with an intraoral scan acquisition of preliminary implant position and soft tissue anatomy. A second impression, digital impression of the temporary restoration and the antagonist. Using the new tools and the new function of the software, is possible to take all of these impressions and to match between them. So at the end, according to this protocol, a prosthetic template can be fabricated. The prosthetic template is used to test the accuracy and to test the function of the patients. The prosthetic template is designed starting from the temporary restoration and the preliminary implant impression derived from the digital impression. This prosthetic template is a copy of the temporary that is a copy of the initial prosthetic setup. So again, the concept of the cross-mounting technique. This is the prosthetic template in the patient mount to test the aesthetic and the function. And also it's possible to show the patient and to take the pictures. To take an accurate impression on implant in case of completed edentulous patient, we use the aesthetic template, the prosthetic template, by fixing the temporary abutment of the template itself using a low shrinkage like resin. So the prosthetic template is fixed in occlusions. That means that we have the correct occlusal vertical dimension and centric relaxation of the functionalized temporary restorations. After that, the second innovation is that the prosthetic template is a screwed and specially designed digital scan replica was screwed to the temporary cylinder fixed to the aesthetic template. This allowed to scan the prosthetic template in the laboratory outside the patient mounts, like a splintered digital impression. So, at the end, silicone materials can also be used to rebase the prosthesis before unscrewing. But the concept is that the prosthetic template, named also aesthetic template because we test aesthetic and function, is used to improve the final accuracy of our impression, but also it's possible to use to match with the original prosthetic volume. At this point, we already test an aluminum train that maybe can be avoided in the future. Finally, dental technician has all the information regarding the accuracy, the prosthetic volume, the aesthetics, function, everyone. So he can finish the prosthesis, in this case, titanium CAD-CAM bar, and definitive prosthesis that will be composite materials. But again, the definitive prosthesis will be a copy of the original plan using to set the implants. There are the intraoral view and radiograph of the final restorations and some follow-up, clinical and radiographic follow-up. So from this to that, from 2013 to 2021, showing the challenging that digital technologies allow to overcome. In conclusion, even if I love digital technologies and guided surgery, innovation is nothing without tradition. Tradition is mandatory, particularly in case of complex patients like Laura. For the reasons, I want to conclude in the same way I started. Digital alone is not sufficient. Tradition must to inspire the modern technologies. I want to thank again the Osstem for this wonderful event and to invite me, but I want to invite all of you at the Osstem meeting in Europe that will be held in Rome 28th and 29th of October 2022. That I am the honored together with the Osstem Europe to organize. So I really thank you again and I hope to see you soon in Rome. Thank you.